Well, good morning, and thank you, Fernando, for that lovely introduction. And it's actually been exciting to watch as the chat, everybody identifies where they're from. I've seen South Africa. I've seen about every place in the United States this morning. So welcome to everybody, and thanks for joining us. Today we're going to talk about airway management, and specifically the case for routine videolaryngoscopy. And the learning objectives, we're going to discuss the history and applications of laryngoscopy, the mechanism and use of videolaryngoscopy, and then the bigger question, can we start to consider videolaryngoscopy for routine use, not just for difficult airway rescue and special situations? We can start our history of airway management with this sad painting of the death of George Washington. George Washington, about 3 years after retiring from the presidency of the United States, went back to the farm in Virginia and came home one evening in the snow with a sore throat. The next morning awoke and was unable to speak. For the practitioners, hey Fernando, I'm seeing lots of people typing in the that they can't hear me. Can you hear me?
Yes, I do. So if anybody is not able to hear, please make sure that you reload your screen or you come out and into the room. But yes, I can hear you well, and many people are hearing you well. So please continue.
Okay, very good. George Washington couldn't speak the next day after his sore throat, and for the physicians and other practitioners in the audience, his airway began to deteriorate. He had a difficult time breathing. In the painting are two physicians at his bedside, one of whom, it turned out, the younger physician knew how to do a tracheostomy, but didn't feel like he could step on the toes of the senior physician, who felt that the proper treatment was to continue bloodletting. I'll come back to that in a minute. Tracheostomy has actually been known since ancient times, and in the 1700s, physicians were actually trained in the technique. The endotracheal tube comes online once we have general anesthetics developed in the mid-1800s, but surgery and anesthesia as we know it today didn't really get rolling until we had both general anesthetics and paralytics in the 1940s. Devices for placements of endotracheal tubes, specifically laryngoscopes, were developed in the early 1900s, and the handle with the Macintosh curved blade and a battery-powered light, as we know it today, came online in the 1940s. So poor George Washington ultimately succumbed later this day to what was probably either a paratonsillar abscess or epiglottitis. And my American lawyer friends like to tell the story this way, that while their lawyer professional ancestors were writing the United States Constitution and creating a new form of government in the world, my professional physician ancestors were bleeding George Washington to death. This is where it's hard not to be able to hear the response of the audience, but my lawyer friends think that joke is hilarious. But poor George Washington needed airway management. And if we think about the story of airway management, for the laryngoscopist, which was for the better part of the last 80 years, direct laryngoscopy is mostly what we have done. We see abnormal anatomy. These are the Cormack-Lehane grades of the view of the larynx with direct laryngoscopy. We call it abnormal anatomy. It's not necessarily abnormal anatomy just because we look in somebody's posterior pharynx and see something that makes it hard for us to intubate. That doesn't mean it's necessarily difficult or that they're abnormal, that the patient's abnormal. It just makes it hard for the laryngoscopist. But there are things that can make airways difficult. And in Colorado, where it's this week, we had a day that was 100 degrees and we had a day with snow. So we're already thinking about skiing and the black diamond and double black diamond marker for the difficulty of the runs. And I think you could apply that propose that most of the airways here that we're going to talk about are difficult, and they're black diamond and double black diamond. Thomas Jefferson probably had quinsy or epiglottitis. Quinsy is, you can see here, looking in someone's mouth, a peritonsillar abscess obstructing the airway, and epiglottitis on the far right here. These are terrible problems for airway management. The good news is epiglottitis we don't see much anymore now that we vaccinate for Haemophilus influenza. So what have we done to augment or to save ourselves from difficult direct laryngoscopy over the years? Many devices. So during my career, since the mid-90s, the laryngoscope bailout techniques have included a lighted stylet, the intubating laryngeal mask Airway, which was actually quite a game changer when it came out in the late 90s, the gum elastic bougie, especially favored by our colleagues in the UK as an intubating conduit. And I bring up the Bullard scope because this is getting close. Most people, probably a lot of even anesthesia professionals, haven't seen this device. This is really the forefather of the modern videolaryngoscope. So this is a fiber optic channel. You can see the, let's see, I can use the arrow here. You can see the eyepiece right here. And that's connected to this channel that runs down to the tip where the lens starts, and the image is carried back up here. Then there's a channel for the endotracheal tube, and then it's powered by the battery of the laryngoscope. It was difficult to use, but the people who learned to use it and knew how to use it in your operating room were folk heroes, because they could really bail us out of difficult situations. We're trying to avoid, all of us who intubate for a living, the fiber optic intubation. I put this photo up here because it shows what it really takes to do an asleep or an awake fiber optic intubation. Is a lot of help, helping hold the patient in the right spot, someone holding a mask, someone driving the laryngoscope, the fiber optic scope there. And we're just trying to avoid that because it's a big show and it's difficult. Not as big a show as tracheostomy though, and we're certainly all trying to avoid getting to this spot. But that is the final pathway when we can't ventilate someone and can't have them breathe on their own. So finally we come to a new state of the art from all these historical stories. Not that some of them aren't still useful, but as I'll show you here in a minute, videolaryngoscopy really has become the state of the art for dealing with the difficult airway, and I'll propose as we go along, it's getting closer and closer to becoming what we do every day. This picture is to make the point that the Bullard scope and the fiber optic scope flexible fiber optic scope for intubation use fiber optic technology, where the actual image is carried from the light source and a lens at the end of the channel back to an eyepiece. And this is different. Videolaryngoscopy uses an actual camera chip and then transmits a signal to a screen. So different technology, but just wanted to highlight that. So there are two classes of videolaryngoscopes. There are channeled devices, and then there are devices that are non-channeled. I'll show you the channeled ones here in a second, but these are the non-channeled devices, and these are the big three that are sold, marketed in the United States. There's the McGrath on the left, the GlideScope series of blades on the top right, and then the CMAC on the lower right. And all of them have evolved to have two types of blades. They have Macintosh style blades that are similar to the direct laryngoscopy blades that we use. and there are hyperangulated blades. So on the far left, the X blade there at the bottom is a hyperangulated blade. The glide scope on the top, you can see the hyperangulated blade, and then the CMAC has what they call the D blade. So both of them are offering something more in a traditional blade and also in a hyperangulated blade to try to get a more anterior view. I'm going to say this a couple times for the practitioners listening to me. It's important to know that the hyperangulated blades, generally the manufacturers do not recommend sweeping the tongue like you would with a traditional Macintosh blade. And so knowing the best way to use these blades is also important. These are the channeled devices. The AirTrack and the King Systems device are the ones sold in the United States. Interestingly, the AirTrack uses mirrors to move the signal, to move the picture to your eye, and then they can have you put a camera on top of that. And if you see why it's channeled here, you can see that the endotracheal tube fits into a channel. When you get visualization, you merely advance the tube into the spot. So these are really a one-step device, and people will make the point that perhaps they don't perform as well in clinicians' hands because we haven't been trained to do the one-step process. We're used to the two-step process with our traditional traditional DL and the videolaryngoscopy with the non-channel devices that I just showed you. So when we think about managing a difficult airway, this is the American Society of Anesthesiologists difficult airway algorithm. Other societies have their own. Everybody who does intubation for a living knows about the thought processes for dealing with difficult airways, both identified and unidentified. And this is a terrific place to start, and we all could probably draw this, off the top of our heads without thinking very hard about it. But it is awfully complicated, and there's a lot of arrows, a lot of decision trees. And if you look at how people perform in the real world, it's very hard to use an algorithm like this in a pinch, or even to think about what you're going to do when a real crisis emerges. There's a recent 2019 article looking at the closed claims project in the United States for airway injuries. And in 26% of the cases of catastrophic outcomes from airway catastrophes, a laryngeal mask was not even attempted for oxygenation. And the review of these cases suggests that when things really get difficult and stressful and a crisis emerges, we don't always have the right thought technologies in place to make the right decisions. I would encourage the practitioners who haven't had any experience or exposure to the Vortex approach to go to this website and take a look at the video that these New Zealand doctors have put together and their new model for thinking about difficult airways. And what they're trying to do is have us focus on the lifelines that we need to oxygenate our patient. And the three lifelines are the mask. Let me use my fancy arrow here just because I can. The mask, the supraglottic airway is represented by a traditional LMA, and endotracheal intubation. And then very sad as we move down the bluer and bluer channel here, always thinking about the cricoid airway, which is a place that none of us ever want to be. But it's a good way to think about that these are the three things that are going to keep us away from the cricoid airway. Of course, also waking the patient up in the elective setting in the operating room. And for each of these lifelines, they try to get people not to be changing things and moving between the lifelines quickly. Another thing that comes out of the closed claims analysis and other discussions is something called perseveration, where people will try to intubate 9 times, even though it's not going any better the 7th time than it did the 3rd time. And this tries to get people to focus on moving ahead, making changes, getting help, but always trying to avoid heading towards the cricoid airway. So when we think about predicting difficult airways, there are lots and lots of ways to try to predict difficult airways. All day long, I'm looking in people's mouths and assessing their neck extension, trying to use the traditional ways to assess the airway. I'm looking at patients' weight factoring in addition to Mallampati scores. But the sad, sad truth is that it is difficult to predict difficult airways. And on the flip side of that, people in whom you predict difficult airways frequently do not have difficult airways. And let's just put that on a big slide of a prospective study of 188,000 patients that's published recently, where people wrote down, were collected data on how difficult the intubation was and whether it was predicted or not. And in this study, the difficult intubations were 1% to 2% of the cases, and 93% of the time it was not predicted. So the difficult airways that come up are mostly not predicted. On the flip side of that, you can look at data that says that in people whom you predict a difficult airway, only 25% of them actually have one. So if you draw out sensitivity and specificity on our preoperative assessment of the difficult airway, it's not very good on either side of this. I will say that the 93%, that's a big number. There are another study that shows 50%, just to throw that out there. So let's look at rescuing. So 93, let's say way more than half the time when we have difficult airway, we did a direct laryngoscopy, we didn't predict it. What's been the trend over the last 20 years for what we're going to use to enhance our ability to intubate that patient? And the answer is that since 2004, it's been a massive movement towards videolaryngoscopy. Now I will highlight here that my favorite early on during this time period was the supraglottic airway conduit. So that would be the intubating LMA. Man, I loved that thing. But videolaryngoscopy just squashed it. You can see that my favorite technique pretty much goes away. And I'm going to bet the only time it's used here is if for whatever reason there wasn't videolaryngoscopy. I'm interested to know who's still using that. But you can see here, videolaryngoscopy, this slide's data is it was 8 years old. So I'm going to bet that this is even a larger percentage now. So we've gone from the introduction of this device to massive market penetration as a rescue tool. And we can show that not only is it getting used, but it's improved outcomes most likely. So you can see on the left here, now that I've got the arrow out, it's irresistible not to use it. And if you're guessing that I'm the guy that gives a PowerPoint presentation with the laser pointer waving it all over their screen, you're exactly right. That's me. So this is the best I can do now. You can see here on the left side, this is 400,000 airways over 2 different epochs in a large North Carolina hospital system. And they showed that over these 2 group time periods that difficult intubations and failed intubations both went down. And on the right, you can see that the percent of the time that videolaryngoscopy was used in a different time period or similar time period, videolaryngoscopy was used most of the time, and it was also the most successful. So increasing use of videolaryngoscopy, and over the same time, we're seeing better clinical outcomes. So now we're marching down the road and saying, well, what about patients? Certain groups of patients should we reach for videolaryngoscopy first? So how about patients that come to us and with the diagnosis of a difficult airway in the past? And let's do direct laryngoscopy on them and videolaryngoscopy and find out which was better. And there's enough studies like this that we have a meta-analysis that shows that, yes, first pass attempt on people that we know have a difficult airway is better, and the view is better, and we probably have less mucosal trauma. So in the known difficult airway patient, it seems easy to say we should probably reach for the videolaryngoscopy first. There are enough studies looking at videolaryngoscopy versus direct laryngoscopy that there's a Cochrane review. So Cochrane reviews are looking for evidence-based practice summaries. There are 64 studies in this 2016 Cochrane review that lead to these conclusions that videolaryngoscopy may reduce the number of failed intubations, particularly if we know they have a difficult airway, compared to direct laryngoscopy probably gives a better view, and it may reduce airway trauma. But the question that we really want to ask is, as we've watched videolaryngoscopy take over our difficult airway interventions as both rescue and primary approach, what about the evidence for and arguments for using videolaryngoscopy as our primary approach to laryngoscopy? And I'll put the Cochrane slide back up there and say they comment on this in 2016. And their comment is, there's not enough data for us to say that videolaryngoscopy is better than direct laryngoscopy for all airways. So as your first approach, that's not to say that there's let me say, I have to think about it before I say this. So the saying is that absence of evidence is not evidence of absence. And I think if you read through these trials, you'll see that actually there are very few studies that ask the question, what happens in the hands of experienced practitioners if you roll out videolaryngoscopy compared to direct laryngoscopy as a primary approach. So I would say that largely my assessment of their comment here is that there is an absence of evidence to support the primary use of videolaryngoscopy, but there's not evidence of absence because there's just very little literature. And if you're listening to this on a recording, you're going to back up and try to listen to that again. There have been assertions by very smart people who think a lot about difficult airways and airway management that we are on the road towards videolaryngoscopy being our primary approach. This is a quote from Miller's newest edition, the Miller's Anesthesia textbook. And they say videolaryngoscopy has revolutionized practice of airway management, and their use may become standard not only for difficult airways, but routine airways as well. And I'll highlight that this quote is unchanged from the 7th edition of Miller's textbook, except that they changed it. In the 7th edition, it said over the past 10 years. So the fact that they haven't changed a sentence means maybe they don't think we're, they still think we're on our way. But people have been thinking this for quite a while. And in this month's Anesthesia and Analgesia, and that's a sad little reference there, PAP is published ahead of print. It doesn't even have a reference yet. The title of the article is Videolaryngoscopy, Is There a Path to Becoming Standard of Care for Intubation? And they say these reasons for yes, that you can see better, you have higher first pass success rates, fewer failed intubation rates, and they add on, hey, you can film it and other people can watch later on and see what you saw and make their plan better in the future. On the flip side, they say that the studies aren't uniform to support it. They especially ask the question, does it help experienced practitioners, especially anesthesia practitioners who intubate all day long? Does video enhance their ability to succeed first pass? And then they bring up concern for pharyngeal injuries. And I think that is mainly with the hyperangulated blades, and I will again focus on that we need to do a better job of learning how to use these devices so that we have less trauma. And another article from 2 years ago Technology of Videolaryngoscopy. This is a terrific review, and I think anybody who's interested in videolaryngoscopy talks about how the devices work, the development of the devices, the different types, and then also a discussion of pro and con for first pass use. Again, pro, same as before. They also say, we ought to be using it more so that we're better at it. On the con, we still need direct laryngoscopy skills. And I'll add here that I think a lot of anesthesia practitioners really do feel like this is our thing, right? I mean, we intubate people. This is the thing that everybody in the hospital looks at us and says, we're the best at in the hospital. And there is, I think, an element of pride that says, man, if we have video, our direct laryngoscopy skills are going to get worse. And then other people in the hospital use video and they don't need us and it hurts our feelings. And so I definitely think there's an element of that. They also say the studies don't uniformly support that position. They bring out which device is best. This is a huge issue. So I've showed you 6 devices that are widely available, or 5 that are widely available in the United States. They appear to be similar, but they're really not. And we need to know which ones in our hands potentially are better. They also point out that better visualization doesn't always equal better success. There's a thing in the literature called "I see that I fail." I actually watched this happen this week with a less experienced provider that I was, helping learn to use videolaryngoscopy. We had a great view of the larynx, but a more challenging time getting the tube through it. So just because you can see doesn't mean that you can win. And possibly there are some studies that suggest that the video laryngoscopy can take a little bit longer. So again, they point out at the end of their study that the literature isn't great here for making the first pass argument completely, and that we need more. But again, these studies that are saying this in these position papers are, this one's a couple years old, and that meta-analysis, the Cochrane review, is a couple years old. So I would propose that I agree with this, except that I know there are studies in the pipeline that are going to do a much better job of answering these questions for us. So here's a study that I think is great because it compares the devices and helps us get a better idea of where we might win. And this is 6 different devices, and across the top there are the 3 devices that I think they've got the hyperangulated blades on them there, but they're the non-channel devices. And on the bottom are 3 channel devices, and they simulated a difficult airway by intubating people who were asleep and had a cervical collar on. And for those of us who do the job every day know that intubating someone in a cervical collar, pretty much the cervical collar does everything possible to hurt us for intubation. But this is great because it showed first pass success rates across different devices. And as you can see on the left, the more traditional devices in our hands did better than the channeled devices. And people will argue, at least one author I read, that the reason that the channel devices don't do as well is because they are a one-step price and one-step process that is different than what we were trained to do with direct laryngoscopy, which is a 2-step process, which is identify the larynx and then secondly put the tube through it, whereas the channel devices are kind of all one step. Once you identify the larynx, you're in position. Videolaryngoscopy in the ICU. So this is moving more towards the first pass attempt genre of studies. This is where they did a quality improvement project where they said we're going to track traditional laryngoscopy in our intensive care unit, and they did 140 direct laryngoscopies, and then they switched over and they used the McGrath Videolaryngoscope, which is one of the non-channel devices, And after 70 with the video laryngoscopy, they reviewed the data and decided to stop it because the video laryngoscopy was so much better for first pass success. Here's another group and another study saying, is there a role for first pass with this group of patients? So patients with obesity, there's actually enough studies for first pass with this, comparing visualization and success rate direct laryngoscopy versus different video laryngoscopy. And the answer with the meta-analysis was yes, first pass makes sense, and they showed a shorter intubation time. So better first pass success, better visualization, shorter intubation time, which in a patient with a higher BMI, we all know we have less time. So that's there. I see somebody noting in the comments, if I've used the word Macintosh where I meant to use McGrath or vice versa, I do apologize. They are awfully close, and your brain can get it. So again, Macintosh is the name attributed to the curved blade for direct laryngoscopy. McGrath is a specific technology. So here's another idea. How about using video laryngoscopy as a quality improvement project, comparing different devices and then seeing what our success rates were and on a large scale. And this is also published this month in Anesthesia and Analgesia. These are the 4 devices that they use. The upper left is the McGrath Videolaryngoscope. The CMAC on the right, 2 different versions of the CMAC. One, which is the disposable blade hooked to a camera. There's one that's called the personal monitor, which hooks directly to the blade unit there. And then there's the other one, which is hooks to the traditional separate screen. And then the lower left is a device called the APA that's from the in the UK, and I'm not aware that it's marketed in the United States. I've never seen it in any of my hospitals. But their question was twofold: how good are these devices if we use our eyes? So if we do direct laryngoscopy with these handled devices, how good is it if we look in there with our eyes to see visualization? And then the follow-up: how good is the view with the video, and what does that add to it? And I think the one looking with our eyes is great, because I do think that people don't want to let go of that. They do want to look with their eyes with the traditional Macintosh style blade. And then they also created a way to add on the ability to switch to the angulated blade. So these guys are thinking exactly like I would think about adding video laryngoscopy to my hospital as a routine first pass. So I would want to be able to look with my eyes with a traditional Macintosh style blade, and then I would want to be able to upgrade to an angulated blade if I needed to. And I'll just give you the summary of when this is too busy to go through, but this is, if you're interested in this topic, this is this month in ANA. And the answer was that for the video quality, the CMAC devices were best. And I think we all have seen that, especially with the big screen. But the McGrath device, compared to the others, gave the best view with our eyes with direct laryngoscopy, gave the best video views, and ultimately had the best outcomes and highest success rates as far as overall attempts. And the providers doing the procedure gave it the best rating for ease of use. So I think this is a really useful study because it gives us some idea of the devices compared to each other, what we might want to try when we're evaluating, thinking about moving towards this. And also, this is an all disposable situation. So I think as we talk about cost and footprint, I like this study because it's fitting into what I'm hoping to do in my operating rooms. Here's another rollout for first pass, for first attempt for laryngoscopy. This is a hospital in England where they just decided as a department to switch from direct laryngoscopy's first approach to CMAC for first approach. They did it for 2 months, and after the 2 months, they reevaluated and ultimately decided as a department that that was the best plan to stick with videolaryngoscopy. This study is actually a couple years old. I'm interested to see if they've stuck with that, but they actually said they took the direct laryngoscopy equipment out of their operating rooms. Okay, I apologize for the next slide. Brace yourselves, because for the last 41 minutes, you haven't thought about this. Sorry. COVID really forced the issue in my operating rooms about videolaryngoscopy as an initial approach. This is the June 2020 APFS, so the Anesthesia Patient Safety Foundation recommendations for intubating with the COVID world, and specifically the COVID patient. And one of their first things they do is say that the most experienced anesthesia professional should perform the intubation, if possible. Okay, so I was on call at my primary hospital last night in-house, and I know who all the other people on call were. I know who was, I'm just guessing who was in the ICU and who's the ER, but I'm old compared to most of them now, and I'm almost certainly the most experienced person in the room, in the hospital, and I hate them calling me out that I should intubate everybody. However, that's probably not a crazy recommendation, at least in that probably we shouldn't be teaching people how to intubate when we're intubating folks with COVID. And then they say, for the purposes of this talk, that a videolaryngoscope is recommended as the primary intubating device to improve intubation success. So, wow, that's bold. So they give a reference for that, and the reference is this paper, which is another consensus recommendation from the Royal College of Anesthetists. So I go to that paper, I'm like, okay, so what's their reference for saying that? And the answer is there isn't one. So they basically, the APSF referenced another paper which referenced nothing. So we really are falling back on our belief system in the studies that we've talked to up to this point, that first pass attempt should be better with videolaryngoscopy, and we believe it enough that we're willing to say it even though maybe we can't put a paper that we love as the reference. And maybe they could say that because this is more of an ICU setting, that all the ICU stuff we talked about, or at least the one paper, but there are others. Maybe that's good enough. Maybe that's good enough for that. But I want to point out, here's what happened in my hospitals when we read that. We said, you know, especially in March and April, we didn't have enough testing. We didn't know who had COVID and who didn't. So we had and now have been treating everybody like they have COVID, even though, you know, knock on wood, in my community, the incidence of the disease is pretty low now. But we know that in the operating room, when we intubate people, that's a high-risk moment for us. So we pretty much early on were using videolaryngoscopy for every intubation. And we took that, we kind of expanded on that and used it for everything. And here's what happened. As people did this across the US, all three manufacturers became back-ordered on all of the disposable VL products. The supply went down. We had a difficult time turning over enough blades. And then we got pushback from from at least one large hospital system that sent us a very long white paper reviewing some of the data that we just went across, saying, hey, look, people, you should not use, or you should consider not using videolaryngoscopy every time. And here's a bunch of studies that say that they have questions about that. So so problems with supply and demand, with demand and supply, I guess in that order, and then concerns from our customers, and concern about cost as well, as we escalated this up. In defense of what happened, if you think back to what was going on in hospitals in March and April in the United States, there was a lot of fear-based decision-making for good reasons. A lot of conservative moves were made, which were reasonable. And quite honestly, the manufacturers weren't ready for the run on their products that happened. And we weren't ready to think about how we were going to implement this. Other considerations for routine videolaryngoscopy. And this is just using reason and logic to apply to this discussion. We got to remember that it's the intubation forces that cause most of the sympathetic stimulation and hypertension and tachycardia when we intubate people. Can videolaryngoscopy potentially reduce that? And the answer is there are studies that suggest yes. I think it's super hard to control a study where you say, okay, we're going to intubate people and find out what their heart rate and blood pressure does the old-fashioned way, because we all know that you can apply different amounts of pressure. So in these studies, I think it might be hard to control for that, but certainly here's a study that showed different hemodynamic responses and that it was improved with videolaryngoscopy. There are studies that suggest that there might be less sore throat with less force, and that just reason and logic would suggest that that's true, in addition to some good data. Here's another one, traditional Macintosh versus McGrath VL in the elderly, less of a hypertensive and tachycardic response with the video intubation. So there's a whole group of patients that you suggest that that's a good idea for, if that turns out to be true. And then other considerations for routine VL. It's first pass versus et al. In these studies you have to look at. Metal versus plastic. I kind of like the plastic blades. I think metal is more likely to, this is just all personal experience here. I'm not going to show you a study on this. I like plastic going across teeth more than I like metal. What are the shape of the blades? And if you're looking for direct laryngoscopy also, do you have all of the pediatric blades available to you if you're wanting to do VL? So considerations there. All three of the major manufacturers in the US, actually I don't have the Storz one here, but I'm sure they have one too. I didn't find that one. These videos are great. They're short. There's stuff in here you haven't thought about. And I think we need to especially pay attention to which blades do we sweep the tongue with and which ones we don't. We need to consider what our training is with them, especially as to when do I look at the screen and when do I look at the patient. The time that I see that we are likely to injure people's mouths, posterior pharynx, is that we're looking at a screen while we're guiding into the mouth with the blade, with the tube. I think that's something we can all potentially focus on more, and I've started to work with trainees on that and think about it myself. Here's another issue when we think about routine videolaryngoscopy as our first approach. Could someone get the glide scope? When you hear that in the operating room, that is just the same thing as saying we have a problem. Houston, we have a problem. And the surgeon notices, the scrub tech notices, probably overhead in the operating room is a call, airway help to room 2. I mean, it's setting, and that's all the correct answer. But it's videolaryngoscopy in some ways or at least adding videolaryngoscopy is creating a production in our operating room. And I am trying to avoid calling attention to myself at all costs. Not at all costs, but certainly when I don't have to. I want things to look smooth and happy all the time. And so I think something that I think a lot about is, what does it look like when I do routine videolaryngoscopy? And there's the old iPad to iPhone comparison here. So the big GlideScope screen, the big CMAC screen are big and beautiful like the iPad, but maybe I can get by with the iPhone version so that I can do this more routinely and not have such a big production and such a big footprint. I am looking for a device that can potentially just live in the same place in my operating room and in every operating room that is the same spot that the direct laryngoscopy equipment lives in. And if I can do that and have the ability to have video and no one even notices and no one has to bring me anything and there's no separate cart, I think that's terrific. And then finally, getting to cost. I said it this way to one of my partners recently: if the video laryngoscope didn't cost any more than the direct laryngoscope, and he almost interrupted me to finish the sentence, I just kind of left it hanging there. He said, yeah, we would use video all the time. And there is so much to consider about cost. And it's complicated. And if you want to make a spreadsheet, there's a lot of stuff that's going to go on it. So for direct laryngoscopy, we, in our minds, because it's always there, and it basically looks like a flashlight with an extension on it. In our minds, direct laryngoscopy is free. And it's not. The handles and the blades cost money. They get beat up. They get lost. They get potentially taken away from RORs to other places. How many uses can you get out of them? How much do batteries and bulbs cost? And then there's reprocessing of the reusable handles. It's not free to transport it down to CS to get it processed. There are chemicals, water, electricity. There's paper to put it back in the package and transport it back up to us. And I think it's interesting, in the lower right here is a picture, I do love this arrow, of a disposable laryngoscope, direct laryngoscope, and blade, and the list price of that thing is $20. So $20 US. Is that what the market thinks that the real cost of reprocessing and maintaining direct laryngoscopy equipment is? And I bet $20 is not what people actually pay for it. I don't know. I have a hospital that has chosen to provide this product in every operating room, and they no longer have, I'm trying to think in the drawer, did they have the old stuff? I don't know that they did, but this is their solution. So maybe the market thinks that the answer is $15 for what it costs to do that. And then video suffers in the cost analysis because in the initial days of GlideScope and CMAC, those base units were $10,000, $15,000, and that stuck in people's heads because that was a big hit. But now some of the disposable blades for the handheld devices is as low as 10-ish bucks. I'm not sure exactly what we're paying, but maybe there's actually, now granted, the hardware for the handheld is more expensive, and it has all the same issues of capital cost and loss and maintenance and batteries, but it might be that our per case costs are actually not nearly as high as we had thought for video. So these are all things that we have to consider when we're looking at it. And then you have to ask it this way too. What is the cost of failure with our airway interventions? And the biggest one obviously being the terrible outcome of a hypoxic brain injury. The suffering, obviously all of us are most concerned with how our patients do. And it's a catastrophe if we have an airway disaster that leads to a patient injury on that magnitude. But you can back it out to be less catastrophic. Well, what does it cost if we just can't intubate somebody, or we try too many times and the airway gets swollen and we have to cancel a case? That's a big deal too. What if we finally do get them intubated and do the gallbladder procedure, but then we feel like we need to admit them overnight just to give them steroids so that we can watch their breathing? That has a cost to it as well. So there are other things. What if we have to send somebody to the ICU overnight? That's a big deal too. So there's this also hard to measure other side of direct laryngoscopy's costs. So I'll put poor George Washington back up here. Can we let go of the past? I think we've been letting go of the past and moving forward with video laryngoscopy for the last 20 years. It's made great inroads. The devices now have sensed what we need, and the manufacturers are giving us devices that fit in our hands, that don't make us have a big production to use them, that are coming down in cost. And I suspect that at some point in the near future, we're going to have to put the question back on other people and say, you need to explain to me why we should use this old-fashioned technology of direct laryngoscopy as our primary airway intervention when it's really not even possibly much cheaper, and it doesn't have as high a success rate as the newer devices. I know that there are barriers for us to still get over on that, but I think that we're a lot closer to that discussion than we were before. So in summary, VL has become a big part of our modern airway management. I think there's lots of data on safety in certain populations, and we continue to get more comfortable about advocating and thinking about routine use. And a lot of practical considerations, cost, footprint, availability, are potentially the biggest barriers to more widespread use. Well, thank you to everybody around the world, and I hope everybody is safe, and I hope the world is healthier today than it was yesterday. And I'm looking forward to questions going forward. And thank you again for taking time out of your day.